Nikolay, I'll just introduce you. Nikolay, I'm sure many people know, has given lots of talks here, is actually has been a friend for a long time. We have worked in a lot of courses and also been involved in various societies, spine societies. He's working in Belfast as spine surgeon and lots of interest in, and even did COVID duty for a little while. So Nikolay, off you go.
Hi, everybody. Thank you, Salman, for the introduction, and thank you, everybody, for having me the opportunity to be here. Hi to Mehmet and to all the moderators. So, pleasure, as usual. Please excuse me for the outfit I'm working today. I'm in theater. I just peeled off to deliver that lecture, and I'm going back to theater. I'll try to make it as interactive as possible. So I've seen the other lectures, and I've heard the majority of the things that I will speak to you about, but hopefully I'll give you something interesting as well. So subaxial spine, and in general, the cervical spine still represents major issue. There is a lot of fatalities and a lot of mortality and problems because of cervical trauma, and we have to deal with the consequences as surgeons, neurosurgeons, spinal surgeons. About 15 to 20% of the fractures will be complicated with severe neurological deficit, and about 50% of the C spine injuries will be happening in that C6, C7 region. About 60 to 70% of the fractures will be a result of road traffic accidents, and about 30–40% be caused by sport injury and assaults. So just to remind you, cervical spine is the most mobile segment of your spine, and the C0, C1, C2 segment is quite different anatomically from the subaxial segment, which is C3 down to C7. Normally, you should have lordotic configuration of your C-spine. Anterior and posterior ligaments are very important for the integrity of the anterior middle column, and the posterior column is maintained by a complex ligamentous system. The posterior column is the main weight-bearing structure. About 70–80% of the load goes through the posterior column, and this is unlike the thoracic and lumbar, where the ratio is flipped over, where 70 to 80% goes through the anterior two columns. The mechanism of injury is important for the injuries that you're gonna analyze and treat, so it's worth establishing that. So there is usually 6 mechanisms of injury that can cause problems and traumatic changes. This is flexion, extension, compression, distraction, torsion, shear, or combination of all these. You can see the different axes of different planes where this can happen. So management of the subaxial cervical trauma, of course, involves the patient assessment in the very beginning. It starts from the very beginning. Resuscitation, establishing the consciousness level. Immobilization is a critical point here. Then you have to go through history, physical examination, neurological examination. You have to examine radiologically, and then try to classify, and then finally go to the management plan. Just make sure that you stabilize the neck properly, and just bear in mind that stabilizing the neck is emergency, but to clear the neck is not as urgent as stabilizing it. So be careful and think about that. So management of the subaxial spine, do we have so much level 1 evidence? Let's see that. Actually, we don't have so much. We have about 9–10 studies which show that the methylprednisolone is not working. This was also already mentioned by Salman. Gangliosides are not working. We have about 3–4 studies about the CT as being the most reliable and accurate investigation for thoracolumbar trauma, and that's it. The rest we decide based on case series and spine expert groups, but we don't have grade 1 evidence for many of the things that we do. So the mainstay of the treatment of the subaxial cervical spine is trying to classify. And in order to classify properly, we need a classification that gives you objective clinical and imaging assessment. It will provide standardized grading of the trauma, will identify any type of injury without miss. I will facilitate the decision making in the fracture, whether the fracture is stable or not, and then we'll give you direction to treat, to fix or not to fix in our case. Unfortunately, we are still in search for the ideal classification that will comply in 100% of the cases with the above criteria. We don't have it as yet. So the first classification that was attempted was by Böhler in 1930, and he described 6 types of fractures. And he realized the importance of the mechanism, and his classification was based mainly on plain X-rays. That is, of course, historical significance now. Then the first sophisticated classification was done by Holsworth, where he defined 2 columns with anterior and posterior column, and he stressed the importance of the posterior ligaments. Then the 2-column classification evolved to 3-column classification by Dennis that was published in 1983. And he postulated the 3-column, and he postulated that it's unstable when 2 adjacent columns are involved. And this is a classification that is still in use in many centers because it's very simple. And then the first comprehensive one came when Magarel and Eby published their classification based on nearly 1,800 cases, which later evolved to AO classification. So Salman already spoke about the AO classification. This is probably one of the most complex and comprehensive classification that we have now. It will identify 9 main groups of patients based on the different mechanisms of injury and different morphology, and will add additional features based on facet joint trauma, neurological status, and also modifiers. Type A is mainly compression fractures with the four types that we have already mentioned in Salman's talk. Type B is injuries of the tension band, anterior or posterior. We already spoke about that, so I will skip further. And type C is a translational injury with displacement in any direction from the vertebral body relative to another. Usually, type C is combined with type or A or B or different combinations.
I think
we have to, in the cervical subaxial spine, we talk about also the facets, and the facets contribute further for classification. The morphology of the fracture, as you can see from F1 to non-displaced facets, which is below 1 centimeter and below 40% of the lateral mass involvement, which is believed to be stable, and the rest of the types are mostly unstable. We have the neurological status, which is important also modifier for your decision making. And then we have general modifiers like the posterior capsular ligamentous injury. We have the morphology of the disc herniation, which is also something that will modify and direct you for your treatment. And we have different general conditions like stiffening of the bone and ligamentous complex, like ankylosing spondylitis, like DISH. And then M4 is possible in your treatment strategies. So unfortunately, this despite it is a very comprehensive classification and gives you a lot of variables, that can be sometimes tricky, and that causes problems with the everyday use. Despite all of us are aware of the AO classification, are practically not in all the centers. This is being used nowadays, and in many centers they still use the other classifications which are easier to use. This is an interesting research that probably explains that. The authors tried to compare the AO classification with the old Dennis classification. 5 observers were trying to classify different traumatic patients with the 2 classifications. And as you can see, with AO classification, the observers reached 0.31 inter-observer reliability, and based on MRI, it's even less. If they combine CT with MRI, they managed to reach nearly 0.5. As you can see with the Dennis classification, inter-observer is 0.6 with the CT. Of course, this was based on the old, not on the last classification that was issued by AO, but still, the new classification is, if anything, it's a bit more complex. So this is a real problem of the AO classification, its complexity, and although it's a very comprehensive, it is difficult to use on everyday use. So this is a treatment concept that you can base on the AO classification. As you can see, all the B types, all the C types are mostly surgically treated. All the unstable facet types starting from F2 down to F4 are mostly surgically treated, irrespective of the rest. With A types, you can choose to treat conservatively or surgically. With A0 and A1, of course, possible to treat conservatively, but A2 and A3 sometimes gives you a gray zone based on the other modifiers. Then it is difficult to establish a proper plan of action, and then you have to rely on your personal experience or the experience of your group. Another so the big criticism of that classification, as we said, is that it is insufficient for the anterior column. It is complex for everyday use, and also has relatively low inter-observer reliability. Sorry. Another classification that is very popular and that was again mentioned today by Salman was the Subaxial Cervical Spine Injury Classification by Vaccaro, or known as SLIC classification. In that classification, we have 3 main categories, which is the injury morphology, discoligamentous complex, and also the neurological status. It's a point system. You assign numerical values to the main 3 categories, and then you sum together, and then based on the score, you have a guidance for your treatment strategy. If it's less than 4, you treat conservatively. If it's more than 5, you treat surgically, and if you have 4, again, you have a gray area where you can apply one or the other based on your experience. This is the classification again. And this is the point system that you can, these are the points that you can assign in the different domains. I'm not going to go in details with that. The main criticism of that classification is that the mechanism of injury is not well reflected. The postural ligamentous complex needs MRI scan. This is not always available in all the centers 24/7. And then the neurological status will need a awake patient that is alert, oriented, and cooperative. So just to remind you again, this is the ideal classification. Unfortunately, we still don't have that, still to be established. Management of the subaxial spine can be, as we said so far, conservative with immobilization. You can immobilize with hard collar, or you can immobilize with hollow vest. Be careful with the snake in motion. This was mentioned by Mehmet already. This is a good paper that will give you information about that. Because of the snake, immobilization could be tricky with the halo vest and actually can give you worse result than without treating the patient without the halo vest. So you have to be very selective. In my center, at least, we are still using halo vest, but less and less. So if decided to treat the fracture, we have the following goals. We have to do reduction in case there is any translation. We have to do decompression in case there is compression of the neural elements, and we have to stabilize. And we can use anterior approach, posterior approach, or combined anterior-posterior approach. So speaking about the anterior approaches, we have advantages and disadvantages with any of those. With the anterior approach, we have good anterior decompression. We can achieve good neurological improvement in case the problem is mainly due to anterior compression. We have a traumatic approach, and we have supine position, which is easier to achieve in trauma patients, especially if you have multi-trauma patient. The disadvantages, you have limited number of motion segments that you can address. If it's more than 3 motion segments, usually this is difficult and probably should not be considered. You have potential for complications, and you have poor access to the transitional zones. Unlike the anterior approach, the posterior approach also has the advantages that it will give you a rigid fixation. It will give you good foraminal decompression. It can give you good deformity correction, and also you have no problems to go to the transitional zones. The disadvantages are that in case you have anterior compression, you may be difficult to decompress. The prone position is also something that could be challenging, and you may have significant blood loss. In some cases, and not only anterior or posterior approach is not possible to be applied isolated, and you may need to combine us, like with this case where you have 3-column injury. So I will conclude here. Managing the subaxial trauma. When you manage the subaxial trauma, clarifying the mechanism is very important for your treatment. Imaging will give you information about the mechanism, but you have to go to history and also to the neurological status. There is no perfect classification. We are still looking for that. Many classifications are there that you can use, but you have to use them wise because they are not ideal. Management varies in different institutions and based on different policies, surgeon preferences, and philosophy. And there is quite often more than one right approach to one and the same problem. And then classifications help for decision making and complications, communication and documentation. And each case should be discussed individually. Thank you so much.
Nikolay, that was excellent. I think you gave a very nice overview of the whole subaxial spine. And you made them revise the classification again, which is good, because unless you do it again and again, you won't remember it. So thank you for that. Excellent talk. Really enjoyed that. Mehmet, do you have any questions for Nikolay before we close?
It's quite nice to stress that whole spine classification for subaxial spine cervical trauma is a very difficult to place everything. And the SLIX classification is nicer. But even with SLIX, you cannot well define whether you have to come from anterior or posterior. You can, they are not nicely placed in place.
Yeah, I think I would suggest that WFNS Spine Committee should have a consensus on this and come up with another classification which is able to
I
tackle
wish,
all the
yes.
problems.
Maybe combination of all.
Yeah,
Probably.
we can.
Why not? Why not?
Okay, great. I think it was wonderful to hear from great speakers. I think I really enjoyed both the talks, learned loads as always. And John, it was really nice of you to host us. We're really grateful and hope to see you soon in future.